Well, good afternoon. Some of you may have heard that I'm giving my talk on spine. I'm not giving my talk on how to be nice to doctors because apparently I've already given that talk. So you guys all know about it. Anyhow, what a great place. If I get distracted and I'm looking out the window, it's probably because a squirrel went by. I tend to get sucked off there. Okay. By the way, that was a great little video, and that scares me because now I'm actually going to have to show people what I'm telling them when that video goes on. It's kind of a cool system. So what I'm going to talk to you today about, let's see, that would be that way, is the anatomy of the spine. So I'm going to go through lots of medical stuff. There is no such thing as a stupid question. You might get a stupid answer. That might happen. But stop me. I'm going through the anatomy of the spine to talk about how doctors think about the spine and how I think the spine works. And this is very clearly an MD-DO kind of a conceptualization. So when I think about the spine, I really think about several segments. We look at the cervical spine, which is in the neck. It really is designed to allow for rotation. And we'll look at how the vertebrae are stacked up and how they articulate, how they have joints together. But the cervical vertebrae are stacked up and their joints are kind of horizontal, designed to allow you to turn your head to the right and the left and tip sideways. And the lumbar spine is really anatomically a little bit different. And so inside the spinal canal, which protects your spinal cord, is the spinal cord, which I think of as like the major cable of information going to the computer, which is your brain, and the nerve roots that go to your arm. So when I see a patient and they're complaining of arm symptoms as well as other body symptoms, I would be looking in their cervical spine, expecting that would be the level that there would be a problem. The thoracic spine is the chest, T1 through T12, and guess what? There are 12 ribs. So each one of these vertebrae have a rib articulating from the spine and coming around and making a cylinder or your ribs protecting all of your organs in your chest. In the canal in the thoracic spine is the spinal cord, and for most people, and when I'm talking about things and saying the spinal cord ends at about T11, T10, that's for most people. Some people it goes down to T12, L1, but really by the bottom of your thoracic spine, your spinal cord is no longer present in the canal. What you see below the thoracic spine is the nerve roots that go down to your legs and to your bladder and your bowel. And the anatomists from the 14th century called it the cauda equina, horse's tail. That's what it looks like. It looks like a horse's tail when you have the spinal canal open and you're looking at it. It is really involved in bending forward and backward. Your spine, as it's stacked up in the low back, the joints of your spine are really designed to work in the front back plane as opposed to turning or side bending. All right, I don't know if I can. Do we have a? Okay, hang on. I have a little video. I think it will load. It did on my computer. Grab a mouse. And it did not. One of the technology people are able to help So we can load that video up if I can get somebody to help me connect to the internet and hook up. So this is your vertebra. The top one on this picture is the cervical vertebra. Oh, I just don't know how to make it play off the internet because I'm old. It's old. I'm old, and it's technology, right?
This is the video?
Right. I didn't know how to. No, go back 2 slides. That one. And I clicked. I tried that. Oh, good. Thank you. YouTube. How many people here remember before YouTube? How many people here remember before computers? Good. How many people here know how to use a slide rule? Oh, that's good. There you go. There was a comic the other day where one of the... Oh, I'll let this...
The bones that form the core of the back structure are called the spine or spinal column. This stack of more than 30 bones, vertebrae, supports the upper body's weight and houses the spinal cord, the nervous system structure that carries signals which control the body's movements and convey sensations. Each of the bones that make up the spinal column has a hole in the center, and when these bones are stacked, it creates a channel that surrounds and protects the spinal cord. The bones or vertebrae that make up the spinal column are not stacked directly on top of each other. There are spaces between them that are maintained by round spongy pads of cartilage called intervertebral discs. Each intervertebral disc is made up of 2 components, the annulus fibrosus and the nucleus pulposus. The annulus fibrosus is the tough outer portion of the disc. The nucleus pulposus is the inner gel material surrounded by the annulus fibrosus. These discs and the space between the bones that they fill give the lower back flexibility. The discs act much like shock absorbers throughout the spinal column to cushion the bones as the body moves. Bands of tissues called ligaments and tendons hold the vertebrae in place and attach the muscles of the back to the spinal column. Small nerves called roots enter and emerge from the spinal cord through spaces between the vertebrae. The spine has 4 regions. Starting from the top, there are 7 cervical or neck vertebrae, labeled C1 through C7, 12 thoracic or upper back vertebrae, labeled T1 through T12, 5 lumbar vertebrae, designated L1 through L5 in the lower back, and finally the sacrum and coccyx, a group of bones fused together at the base of the spine. Intervertebral discs are located between each vertebra from C2 through S1. As we age, a number of changes can occur in the spine, which may contribute to or cause lower back pain. For example, the annulus surrounding each disc begins to develop tears and cracks, which can cause pain and inflammation. The discs also begin to lose the water that keeps them spongy and enables them to absorb shocks and help protect the spine. As the discs lose water, they become compressed or flattened, which reduces the space between the vertebrae. In turn, the facet joints that connect the vertebrae and allow for easy movement are compressed. Pressure builds on the cartilage that covers and protects the bones from rubbing directly against each other, which can damage the joints. These changes may result in looser, less stable movement, which further increases the process of degeneration. As part of this process, the tough outer ring of the discs may develop larger tears so that the nucleus bulges out, what is commonly called a slipped disc, pressing on the spinal nerves and causing inflammation. The vertebrae may also lose mineral content so that the bones become thinner and the spinal column becomes compressed or packed together, causing pain. Bone spurs caused by aging and overall use of the spine may also form on the vertebrae and press on the nerves of the spine.
Well, we can.
Yeah.
Yep. It's
you tired of diets that don't work?
No, go ahead, turn it off.
Afraid of complications?
Because you're
from traditional
getting
weight
a
loss
commercial.
surgeries?
Yeah, just turn it off. We'll go to the next slide. Thank you. Perfect. Thank you. Yay. Okay. This is not slide rule stuff. So on the top slide, I don't have a little laser, so I'm going to walk over and point out that this is the articulating surface. So these are stacked vertically, and the articulating surface is horizontal, allowing for rotation. You have much more rigidity in the thoracic spine because they're more horizontal, and then these are down in the lumbar vertebrae so that you can bend forward and backwards. You don't get a lot of motion, okay, in the thoracic spine because this is a rib that comes around and makes a big circle. And that in and of itself limits how much thoracic spine motion there is. So some of the things that I see in practice, and you may be told about, is congenital deformities, one of which is called spina bifida. And spina bifida means it's bifid. It never made a complete ring. So what it means is that usually in the lumbar spine, it didn't form into a solid ring, and this is where the spinal cord gets protected. So this area is open. It's congenital. You can have spinal stenosis because the pedicles, that's what this is called, are short. You have them at every level, and it makes the canal narrower. And you can have a cyst inside the spinal cord itself called a syringomyelia. And I only put that in there because it's a cool word. Okay, everybody practice that. So when we talk about injuries to the spine, it's a little different than congenital deformities. So this is an X-ray picture of somebody who had an infection in one of their discs. And the radiologist will tell you there's evidence of swelling and inflammation because you can see how the bone surrounding the disc is much darker. That means there's more fluid there and the body is reacting. And you get a bulge backwards. This is an image with the spinal cord coming through. You can have inflammatory arthritis. This is called bamboo spine, ankylosing spondylitis. Those spurs they talked about grow across, and the discs are actually in here, but now the discs don't work. And the spine becomes a rigid pipe. And this is important because when people get in accidents, fall, get dropped in the radiology suite, these things break. And inside that canal is the spinal cord. So what we talk about, this is probably more common where people get x-rays and you say, you're told they have these great words, spondylo, they have degenerative arthritis. What the heck does that mean, right? So here, what you can see is that the vertebra is square. This vertebra is square. It's a little wedge-shaped. It's not square, and it's slid. So the back line here does not match the back line of that vertebra. That's called a spondylolisthesis. They've actually slid, which indicates not only degenerative arthritis, but loose ligaments that allows the spine to move. Other things you can see, this is a tumor. The reason you can tell it's a tumor is it's bulging out, it's very symmetric, and there's not a lot of fluid in the bone above and below. You'll have to trust me on that because it doesn't project well. So tumors look different. than infections, and they look different than arthritis. So what kind of injuries can you get in the spine? So the first thing we think about is direct trauma. And direct trauma causes a piece of bone to break. So this is a cervical spine vertebra, and the ring is broken open because these bones do not line up. Here's another one, and understand that down, this person's laying in an MRI machine, so down is the back of your neck. Your throat's up here. So we have broken rings. We can get compression fractures. So the vertebra in the front gets squished and made into a wedge. That requires bone breaking. Both of these. This is typically from a flexion or extension, a whiplash injury, if it's severe enough. Can be from direct trauma. This is from a flexion injury or a vertical compression injury. So in the lumbar spine, that happens when people jump off of heights and land. You can get trauma to the spine, and inside that canal is the spinal cord, and you can get an injury to the spinal cord. And what kind of injury we describe as doctors is based on what we see neurologically. So you can see a central cord syndrome, and that's usually from loss of blood flow. In the thoracic spine, there's a little artery that comes off the aorta called the artery of Adamkiewicz. I have no idea who Dr. Adamkiewicz is, but I'm pretty sure he's the guy who found it in old anatomy. And what you get is what we call anterior spinal cord syndrome, where this is where the columns for motor control are to your legs, but this is sensation, and the sensation is intact, you just can't move. Brown sequard lesions are classic from stab wounds into the spine, and half of the spinal cord doesn't work, and so what happens is you lose strength on one side and sensation on the other side. And that has to do with how the nerves come down from the brain or go up from the spine and where they cross over. So when I see people with pain, the question is, what kind of injuries did they have? So we see lots of soft tissue injuries, sprain and strain. When they're prolonged, at least in my opinion, more than 4 to 6 weeks, the question is, do we have a myofascial pain? What the heck is that? Good question. So the difference is a sprain and strain usually gets better in 4 to 6 weeks. That's the normal healing process of your body. It's kind of like when you cut your skin and you get a scab and then it heals over. In about 4 to 6 weeks, you should have a scar and you don't need a Band-Aid anymore. Myofascial pain is as a result of injury, the muscle becomes irritable. It's not inflamed, although my patients, your clients may say, I feel inflammation, but they have muscle spasm and they have shortened muscles. And muscle's response to pain from the computer above is to make the muscle get tight so that you don't move, because it doesn't hurt if you don't move it. And you wind up in a vicious cycle of tight muscles that get stretched, they go into spasm, and they go tighten up again. Myofascial pain. So when you have your client go out to see a doctor, you got to look at those reports, right? And you guys all remember from anatomy and physiology classes, don't you guys get those in law school? No? Really? Okay. So, as usual, these are the important things, both for the doctors and for you. What history we get from the patient, what their past medical history is. Hopefully your client has told the doctor whether or not they have a problem before. They don't always tell us. They don't always tell us when we ask them that either. What medications they're on, because medications modify people's examinations. That's what they're supposed to do. They treat people, so you would expect if somebody had muscle spasms and we gave them a anti-spasm medicine, they won't have spasms when we examine them. That would be what I would expect. So we do a pretty important orthopedic and neurologic exam. And as a rehab doc, I focus on something that's really important called function. So I do a motor examination that includes reflexes, pretty hard to fake reflexes, strength examination, we do a sensory examination, and then I ask for function. So my classic example, I just saw a patient yesterday who I'm examining the patient, and I know they've had 2 back surgeries, and the person can't tell me why they had the back surgery. So I'm examining them, and I'm having them walk on their toes, and they have no problems, but as this person is walking on their heels, turns out they can't walk on their heel on the left foot. And so my question is, did you ever get told you had a foot drop? Oh yeah, that's why I had my back surgery. Well, that makes sense because they have weakness in a muscle to hold up their foot, and that's a pretty good medical indicator that there was a nerve damage resulting in muscle weakness. So that's an exam that matches a function, and for a lot of you, you've heard about Waddell's signs. Does anybody know what they are? No? Does anybody heard of them before? Waddell's signs? So Dr. Waddell, who actually did practice in Ketchum, I think, for a while, wrote an article about 5 different kinds of exams you can do on a patient that are functionally based, they're not physiologically based, so that it predicts for a non-physiologic exam when you have them. That means something's not making sense. So if they do straight leg raising while they're laying on their back, and they tell you it hurts at 50 degrees, and then when you examine them when they're seated and you lift their leg up and it goes to 90 degrees and they don't have any complaints, trust me, straight leg raising laying down and straight leg raising sitting up is still straight leg raising. So those 2 things don't match. That's functional examination. So in the neck, the cervical spine, when I go through this examination, these are the things I'm thinking about. A pinched nerve root in the neck has a fairly typical, or what I call stereotypic distribution of pain. It's different than the referred pain distribution from myofascial pain. So, but they both have fairly stereotypic distributions. Ligament pains are local, so when we push on people and we examine them, they tell us where it hurts. And joint pain occurs when you move the joint. If you're not moving the joint, typically you don't have a joint problem. So we take a history. In the whiplash injury, you would want to know if they took direct injury to their head. So you want to know, did the airbags go off? Did they hit their head on something? Did they hit the pillar? You look for the pertinent positives. So not what they didn't tell me, but what they do tell me is positive. We do maneuvers that try to close those holes. On the video we talked about where that nerve root comes out. So it turns out that because the nerve roots come out in the back part of the cervical spine, when you tip your head back and you turn the head to the side, it closes those holes, and patients normally tell you that it goes down a particular distribution. They complain of arm and neck pain that fit that nerve root. You want to make sure it goes down the correct sensory distribution, and you want to make sure that their reflexes that match that distribution have a change. So if somebody has a left C7 root distribution, they should have pain when they tip their head back. It should go down the back of their arm into usually their fourth finger, and their triceps reflex should be decreased. When those things don't match, it means that it's not a radiculopathy. People can have pain in a root distribution. We would call that radiculitis, but it is not a radiculopathy. So the differential in the neck and a whiplash injury is, do they have a pinched nerve, a radiculopathy, or do they have a myofascial pain? You do that by distribution, their clinical exam, whether or not they have pain or they truly have weakness. And when people have weakness on examination, it means there's ongoing nerve damage, or there's a history of nerve damage, like I gave you. You look for sensory loss. The difference between myofascial pain and radicular pain is myofascial pain is typically in an area, it's regional, it's not all over, it's not fibromyalgia, that's a different diagnosis. People have tender points, they have associated other issues. The word paresthesia means they have discomfort or funny feelings in a nerve root distribution, but they do not have loss of sensation. And finally, their referred pain is different. So people who have myofascial pain in their neck often complain about numbness and tingling on their head. Headaches behind their eyeball is a classic example of a referred pain from neck muscles. So in the thoracic spine, the root levels, the nerve roots that come out, go around with the ribs. So these are people who will tell you it's not that their pain goes up and down their spine, it will come around their ribs. The other people who complain about this are people who have infections in their nerve roots. We call it shingles. If it's herpes zoster, which is chickenpox, and they will develop blisters, but you can have a radicular or root level pain in that distribution. People who have muscle problems have problems with deep breathing because their muscles are spasming, and your thoracic muscles help with deep breathing. They stabilize your ribs so that you can take a deep breath. Again, local problems are ligaments, and rarely do we see thoracic level joint problems, with the exception of people who have inflammatory diseases unrelated to trauma. So finally, when we get down to the nerve roots in the lumbar spine, we're looking for signs of tension or irritability when you pull on the nerve root. Straight leg raising is a classic technique to stretch a lumbar nerve root, and it should be positive regardless of the position you have the patient in. You'll see spasms and referred pain, so people with low back pain who have muscle spasms typically tell me they're having hip pain, and they point to the butt muscles. It does not go down their leg, and typically muscle pain does not go below your knee. So we talked about the range of motion and inflammation causing joint problems. These are people where you can begin to say where the problem is, more importantly on x-rays. X-rays are probably the best looking for fractures and anatomy. A CAT scan would be reasonable. An MRI is much better at soft tissue and does not give you a good picture of the hard bony anatomy. Discograms. How many people here even know what a discogram is? okay, one person, two people, good, forget it. I mean, no, don't forget it. Discograms are really controversial in the healthcare field. I think they're going a little, I can't tell. I'm not seeing as many of them. Discograms are where they put a needle in your disc and then they put some fluid in and they decide, or based on what the patient tells them, it's concordant or non-concordant, meaning that pressure causes their symptoms. People have used that as a reason for doing surgery, but it turns out when you look at the medical literature, the outcomes are not better than examining the patient. So I don't think very many people are doing them anymore, but you will see them. It is controversial. EMG is a little different. Does anybody know what an EMG is? Good. They're really, really expensive, so just get used to oh, wait, I do them. An EMG is where it's a two-part test where you do a nerve conduction test, where you give them a shock along their nerve and measure how fast it goes. And that will tell you whether the nerve has lost some insulation, so it goes faster. The needle part tells you whether there's permanent nerve damage, because though we cannot look at the nerves, we can look at the muscles, and you'll have to trust me, physiologically, muscles have to have nerves to function normally. So real quickly, a new injury, it's acute, new weakness, they should have an abnormal EMG, but it will take 21 days to be sure. So somebody can have an injury and not show anything on EMG for up to 21 days. We'd see swelling on the MRI, bleeding or hemorrhage. Having a recurrence, no new damage, but you can see a worsening of symptoms that should be able to get back to the way it was before. And an aggravation means there's a permanent worsening of something that was there before. I think I'm out of time, so I'm going to go ahead and wind up and answer any questions, if anybody has any. Yes?
Does the annulus fibrosus have nerves?
Okay, so the question was, is the annulus fibrosus have nerves in it? And that is not a 100% acceptable, no, that's the wrong way to say it. Not everybody agrees that it does. Most people feel there are some nerve fibers in the annulus, so you'll hear a thing called a discogenic pain. And some people think that's from annulus tearing. Some people feel that's from annulus bulging. Here's the problem with that. When you look at the scientific literature and you say, okay, if I see a bulging and people complain of pain, that's where it's coming from, because that's where this discussion comes from. We know that if you put 100 people who are 40 years old without pain, no pain, in the MRI machine, 40 of them will have bulged discs in their lumbar spine. And if you do the same with 150-year-olds, 50 of them will have bulged discs. And if you put 160 years olds, are you guys seeing a pattern here? 60% have bulging or changes. So the question really, even though you're asking me, is it, do they have nerves? The answer is yes, they have nerve fibers. The question is do they cause pain? And that is not clear. So when you have these studies that show it's normal to have disc bulging and people do not have symptoms, how could that be if they have nerve roots? If it's bulging or it's torn, they should have pain. But these are people who got in the study because they didn't have any pain. That's why it's controversial. Any other questions? Yeah.
You didn't talk much about inflammatory autoimmune injuries to the spine.
Correct.
I don't know, I mean, in terms of, when you were showing the pictures of inflammation, that kind of autoimmune, like the transverse myelitis type thing, what does it look like in comparison to what you showed as far as arthritis?
Okay, so the question was, I didn't talk very much about autoimmune or inflammatory diseases of the spine, and then you brought up transverse myelitis, which is actually a injury to the spinal cord, a little bit different. Sometimes it comes from inflammation, but when you see inflammation, there's a couple, three things that tell you it's inflammation. Number one is, just like inflamed bones on the spine, your scans are going to show you, the MRI is going to show lots of edema and lots of swelling. We didn't talk about it because I was trying to concentrate on some basic stuff, but inflammatory diseases cause elevation in blood tests that we measure for inflammation. Very specifically, I use a Westergren citrate and a C-reactive protein. And they're not very specific, meaning they can't tell me why there's inflammation, but if I saw what you're talking about and I got normal levels of that, I would not be thinking about an autoimmune inflammatory disease. And having said all of that, you can get what you just said, an inflammatory transverse myelitis from multiple sclerosis, and have normal tests. So it's really, it's hard to answer your question because it's not exactly perfectly clear. The big ones we see are related to injury is an infection in one of the discs or an infection in one of the bones, and discitis or osteomyelitis of the spine can be a result of direct trauma or bacterial infection and seeding into those anatomical locations from treatment, if that makes sense to you. So I don't know if I answered your question.
I think you did.
Whoa, okay, it was accidental. Yeah,
Actually, I have one more question.
Sure.
What's the prevailing thought in the procedures?
IDET, I-D-E-T. I don't really, the answer to that is I can't tell you what the prevailing discussion is. I don't know of anybody who's doing it right now. And that was a technique where we used to put little wires in the discs and coagulate to make a scar, to make it harder. I think it's gone the way of chymopapane, which was what we used to inject in discs when they bulge out. It's Adolph's meat tenderizer. And it turns out that the outcomes aren't better. And in fact, at least with chymopapane, I know it's worse. I don't know anybody who's still doing IDET, but
They're still doing it in
North
North Central Idaho areas.
Central Idaho? Cool. I think the outcome studies say it doesn't work well. So people may still be doing it. I don't know what to tell you about that.
Any questions?
Well, thanks for putting up with me.
Thank you, Dr.